Hello everyone, thank you for being here with us today. My name is Lauren Heinecke. I'm a doctor of pharmacy and an assistant professor of pharmacotherapy at the University of Maryland School of Pharmacy. And today we're going to be talking about something that I'm passionate about and I think is truly a conversation that we need to start having more in pharmacy, and that's specifically related to medication safety and really focusing on transitions of care. So by the end of our talk today, we should be able to identify risk factors for patient readmissions to the hospital. We should be able to identify the top reasons for preventable errors that occur during transitions of care. After that, we'll be able to list 3 key components to a successful inpatient transition of care program. And finally, the most important part of what we're talking about today is defining the roles of a pharmacist in minimizing medication errors during care transitions. We're going to talk about the role of a pharmacist in lots of different arenas and potentially roles of pharmacists that haven't even been developed yet. So just to get us all on the same page, I thought I'd talk a little bit about what are transitions of care. So this is really the movement of patients between healthcare practitioners, settings, and home, really as their conditions and their care needs change. And I think that's really the key, is that their conditions and the needs associated with their care are really what generate our best idea of where the patient would be best cared for. Do they need to go home? Do they need a hospital? Do they need a long-term care facility? What's the best place for the patient to receive the care that they need? And so there's lots of movement that can occur, a lot of transitions that people probably don't even think about. So some of the ones that are probably the most common are somebody moves from a higher level of acuity to a lower level of acuity, from an intensive care unit to the floor. Maybe somebody moves from between healthcare systems, so they go from a hospital to a long-term care facility, or they're at a community hospital and they need a higher level of care, or they need a procedure or a specialist that's not at that hospital, so they get transferred from one hospital to another. They get transferred between providers, so the team often during the day is different than the team at night, so transitions between providers. And in teaching institutions where the interns switch every month or every 5 weeks or whatever the schedule is, they transition from one intern to another. We also have changing attending. So there's lots of transitions. They're constantly occurring. And while adverse drug events can occur at any time, the greatest risk of an adverse drug event is really during a transition of care. So just an interesting statistic, one of the first studies that identified errors during care transitions found that over half of the hospital medication errors made by prescribers were actually attributable to errors that were made when ordering medications at the time the patient was admitted to the hospital. And this is where medication reconciliation comes into play. I'm sure many of people are familiar with that term, but I think that's one of the big reasons that there's been such a push to make sure that we're doing accurate medication histories, particularly when people come into the hospital. And of course, I'm a huge numbers person. I think if we have a better understanding of the number of discharges and hospitalizations that occur in the U.S. on an annual basis, makes that much more of a strong case for this transitions of care discussion. So it's estimated that annually there are about 38 million discharges. That's a lot of discharges. And because there's been a pretty big focus on the Medicare population, about 13 million of those are Medicare beneficiaries. One of the pieces that often gets left out in the transitions of care conversation, we talk about readmissions to the hospital, but we don't frequently talk about high users of the emergency department. And so we'll talk a little bit about emergency department visits, but on an annual basis, there's about 136 million emergency department visits that occur in the United States. And so I think including emergency department visits as we talk about transitions of care is a very important part of this. So as I was preparing for our talk today, I came across this quote, and I really liked this quote. I think this is a very telling quote about the way healthcare is delivered today. And so it says, "The period following discharge from the hospital is a vulnerable time for patients. Gone are the days when patients had lengthy hospital stays, were cared for in the hospital by their family doctor, and were discharged home fully recovered." And so really what's happened is that as folks have tried to reduce healthcare costs, our hospital stays have become shorter and shorter, and people have really tried to shift care back to the outpatient arena. It's significantly cheaper to do things on an outpatient basis where you have the cost of the test and maybe a facilities fee, but you don't have the cost of all the extra staff that going into running a hospital and maintaining, all the things that occur in a hospital. So ultimately what's happened is that patients are discharged sooner. Ultimately, when they return home, they're sicker and generally require higher levels of care. And they really are, in general, in need of additional care, more care, follow-up care in the community, which makes, I think, care more tricky, more difficult to coordinate, and I think has led to some of the problems that we see in terms of people being readmitted more and more. So what are the numbers associated with hospital readmission? So some of the best data that we have actually comes from Medicare data. And this is a retrospective study that was conducted by Jenks and colleagues. It was a retrospective review of Medicare data. And they were looking to examine 3 questions. The first was, what is the frequency of unplanned and planned rehospitalizations within 30 days after discharge? We know that after people are discharged from the hospital, they're at risk for rehospitalization. So how long is that elevated risk after discharge? At what point are patients not at high risk to be readmitted? And then what is the frequency of follow-up with outpatient physicians after a patient is discharged from the hospital? So what they found in this Medicare data is that about a fifth of patients, or 20% of patients receiving U.S. Medicare benefits, are readmitted to the hospital within 30 days of discharge. The cost associated with these readmissions was estimated to be about $17 billion. This is 2004 data, so might be slightly higher today, but probably not a huge difference. And then about a third of patients who are receiving U.S. Medicare benefits are readmitted to the hospital within 90 days of discharge. I think one of the most interesting things that they found is that patients who were readmitted within 30 days of discharge, only about half of them had seen their primary care physician in between hospitalizations. We'll talk about really the role of the PCP and how important the PCP is in preventing rehospitalizations, as well as the communication between inpatient and outpatient physicians. As we talked about on the previous slide, patients are being discharged sicker, so the PCP really is, I think, the crux of how we decrease readmissions. Also, as part of the same study, they took a look at specific disease states and which disease states were at higher risk for readmission. I think it's important to understand the risk factors associated with readmission, because certainly we know we can't target everybody for risk of readmission, but at least if we can have some low-hanging fruit, some of the disease states that are most commonly readmitted, maybe that's a good place for us to start thinking about how to approach readmissions and put into place some things that would prevent people from coming back to the hospital. So just to orient you to this graphic, on the left-hand column you have the condition at index discharge. The subsequent column is the 30-day rehospitalization rate, and that's a percentage. You also, in the subsequent column, you have the proportion of all rehospitalization. So they took a look at both medical and surgical reasons for rehospitalization. This particular slide is only going over the medical reasons because the majority of people who are readmitted were medical reasons. The subsequent column is the most frequent reason for readmission, so disease state, and then the second most frequent reason for readmission. So as I mentioned, this is the medical reasons for readmission, admission and readmission. When compared to the surgical reasons for admission and readmission, only about 20% of those folks were readmitted. So the majority of people, about 3/4 of the readmissions in this Medicare study, were for medical reasons. The disease states that are at the top of the list in terms of readmission rates are heart failure, pneumonia, COPD, psychosis, and GI problems. So I think that these are some nice disease states to start thinking about in terms of where we can really get the most bang for our buck in terms of interventions for these populations. In terms of reasons that they were readmitted, the most common reason for readmission among heart failure folks was heart failure followed by pneumonia. People who were initially admitted for pneumonia, their most common reason for being readmitted was pneumonia, and then after that it was heart failure. So those two seem to have some interplay together. COPD, the most common reason for readmission was COPD followed by pneumonia. Psychosis, most common reason for readmission was psychosis followed by drug toxicity. And then with GI problems, the most common reason for readmission was GI problems. So I think the big thing associated with this is we seem to not be doing a good job of addressing the main reason that folks were admitted in the first place. And I think, again, part of this does have to do with follow-up. There was another study just to take a look at some other patient factors that aren't necessarily disease state oriented in terms of risk for readmission. This was a case control trial that examined the associations between baseline patient factors and potentially modifiable hospital discharge factors and hospital readmission among elderly patients, and this was specifically done in a capitated managed care plan. So they had about 300 patients that were enrolled. The mean age of the population was 75. A little over half of the patients were women, and the majority of patients included were Caucasian. Just of note, a third of the population had greater than or equal to 5 medical comorbidities. So we're talking about a group of patients that was elderly and as well has relatively complex care. So what I have here for you in this table, these are the factors that they found in the study that were significantly associated in an unadjusted analysis with readmission. So on the left-hand side, you have the risk factors in that column. The next column is the number of cases and the percentage of cases. Cases are those that were readmitted. The percentage of cases with the particular characteristic or risk factor that's in the column beside it. After that is the controls and the percentage of folks in the control group who had the characteristic listed in the far left-hand column. And then our far right-hand column is the p-value associated with it. And so you'll note that all of these p-values are less than 0.05, so we're statistically significant. They've broken the risk factors down by factors present at the time of initial admission and then factors present at the time of initial discharge. So they have broken them down that way. Basically what they found is that age greater than 80 years of age, previous admission within 30 days, greater than or equal to 5 comorbid conditions, history of depression, and pre-illness cognitive or functional impairment were the risk factors that really increased the rate of readmission among their cases. In terms of risk factors present at the time of initial discharge, if the patient had an acute mental status change within 24 hours, that increased their risk of readmission, as well as failure to ambulate, greater than or equal to 10 discharge medications, no patient or family education documented, and discharge to an extended care facility. So I think this, again, just helps us to think about which patients are the patients we need to be spending a little bit more time on preventing readmission and making sure we've got some interventions in place that help them to transition back into the community or to their extended care facility in a way that is safe. Okay, so now that we've talked a little bit about specifically hospital readmissions, I do just want to touch on emergency department visits after hospital discharge. And we're not going to be spending a lot of time on this, but I think it is an important consideration when talking about this topic. So certainly emergency department visits after a hospital discharge can reflect poor transitions in care. It is a marker that's used by policymakers to evaluate innovative care delivery programs. So I think it's an important piece of the conversation, but the role of the emergency department in the post-discharge period really has yet to be clearly defined. So I think there's a lot of research that's still to be done in terms of helping to define exactly how the emergency department really fits into this puzzle. But there was a study that was conducted in California, Florida, and Nebraska, and they took a look at all hospital discharges. It was a total of 5 million discharges among 4 million unique patients. What they were looking at is really what specific disease states increase the risk for readmission. So we're talking about 5 million discharges, and what they found is that there were 1 million who were readmitted, and of those, 40% were emergency department visits. So not quite half of those readmits or ED visits were actually ED visits. So if we leave the emergency department visits out of this conversation, we're missing a huge group of people that are utilizing healthcare resources and healthcare dollars. So certainly this is part of the problem and part of the discussion. And just to orient you to the graphic that I have up here for you, they have the discharge condition on the left-hand column, and then they have the discharge condition broken down by patients without Medicare coverage and patients with Medicare coverage. And I think the reason that they broke it down this way is we're really talking about two different populations. It's important to understand which disease states are probably associated with the two populations. And then in the right-hand side of the graphic have the number of discharges and the encounters per 1,000 discharges And the bar graphs represent the readmissions and the emergency department visits. The readmissions are in the lighter gray bar, with the emergency department visits in the darker gray bar. So for patients without Medicare coverage, the most frequent reasons for readmission as well as emergency department visits included really chest pain and psychoses. For patients with Medicare coverage, most common reasons for readmission and emergency department visits were pneumonia and COPD, as well as heart failure. So a lot of the same disease states that were identified in our Medicare study and were risk factors for readmission are also risk factors for visits to the emergency department. So I think, again, it just really gets at these are the folks that we really need to be focusing on, at least initially when we talk about improving our transitions of care. And of course, because we're pharmacists, I think it's important to talk about the medical errors in transitions of care. So how common are they? Well, about half of patients experience at least one medical error upon hospital discharge, and about a quarter of them will experience an adverse drug event as a result of this. Which populations are at the greatest risk for experiencing a medical error and an adverse drug event? Well, it's our older adults, our patients with limited health literacy, patients at the end of life, children who have special health care needs, patients who take greater than 5 medications, so people with more complex care, patients with cognitive impairment, as well as patients who have complex medical or behavioral health conditions. They have coexisting disabilities and lower incomes, those who are newly admitted to long-term care facilities, and those who move frequently and are homeless or are homeless. So I think a lot of these risk factors make a lot of intuitive sense and are not surprises to us, but I think it does, again, get at who are good targets for interventions and for these programs. Not that everybody doesn't need them, but certainly we know that there's a higher risk group that we should probably be spending a little bit more time with. So I think the next question after that is, why exactly are these errors occurring? And so there's an article in the Annals of Pharmacotherapy that was a really nice article and really was talking about the role of the pharmacist with all the legislation that's currently coming and all of the changes that are currently being proposed in terms of healthcare delivery and healthcare in general. And so there was this diagram that sort of showed what should happen in terms of the patient care cycle. So we'll start at the bottom. Patients start out in community practice. They've got chronic disease states. They're involved with collaborative practice. They essentially have an acute on top of a chronic disease state and go to the emergency department. After that, they're admitted to the hospital, and medication reconciliation is hopefully taking place. There are likely evidence-based protocols that are being used to manage these patients. And hopefully they get some discharge counseling so that they know any medication changes that had occurred. They know about what happened in the hospital. They know about what their follow-up plan is and their plan of care is. They're then discharged, and hopefully we've got some nice handoff to coordinate our care between our inpatient and our outpatient providers, and then they're returned to their community practices. And a quote I think that really spoke to me as part of this article is that, as an inpatient provider, I think it really spoke to me, but the excellent and innovative care that pharmacists provide in the emergency department and institutional setting, really in our ambulatory care settings as well, it may not translate to a reduction in inappropriate readmissions unless we change the discharge process and the transition back to community care. And so the question is really, how do we do that, and what are the pieces that are really causing a lot of the problems? So if you go to the literature and take a look, really greater than half of our preventable errors that occur soon after discharge can be tracked back to poor communication. So the question is, poor communication of what? So pending test results, so something that's been done in the hospital, but the test result isn't back or not completed before the patient is discharged. So that is something that needs to be followed up on, really something that inpatient physician should be following up on and discussing with the outpatient physician if there's anything that needs to be done. The next thing is non-urgent but actionable test results, and I'll give you an example of this. So I think we find a lot of incidental findings on radiology studies that are done. So somebody gets a chest x-ray or a chest CT and they see a small nodule. Something the radiologist isn't concerned about, but they say, hey, this person really should have follow-up imaging done in 6 months just to make sure that it's nothing to be worried about. It's not getting bigger or changing. If that's not communicated, let's say it was actually lung cancer and there's no reason for them to have any sort of additional imaging and no one was told about the follow-up study that should be done. 2-3 years later, the person has shortness of breath, maybe constitutional type symptoms, B symptoms, it's found to have metastatic lung cancer. Had that been communicated, that small nodule, it probably would have been caught significantly earlier, and we probably would have a decreased morbidity and mortality associated with that. So that's sort of an example of a non-urgent but an actionable test results. Then the last piece, and I think the piece that probably is going to resonate most with the audience today, is the medication reconciliation piece. So I already presented data that really said 50% of the errors that occur are on that initial admission and transcription, and that gets back to really, are we doing good medication histories and medication reconciliation? To delve just a little bit more detail into the specific types of communication and maybe why the breakdown in communication occurs, I wanted to just present a little bit more data from the literature. So in terms of direct communication between inpatient and outpatient physicians, in a study by Crippolini and colleagues, it was found to only occur about 3 to 20% of the time. I think that's a pretty small number of times where there's actually direct communication. So the way that most of the time inpatient and outpatient physicians are communicating is really via the discharge summary. And then the next question is, how frequently does that PCP actually have the discharge summary at the visit, which would really, I think, allow them to intervene and make appropriate interventions at that follow-up visit. So at the PCP, the first visit after discharge, the discharge summary was only available about 12 to 34% of the time. And interestingly enough, the JCAHO standards in terms of when the discharge summary should be completed needs to be completed within 30 days of discharge. I think this is something that probably needs to be addressed in terms of the JCAHO standards. When they were written, a lot of times it was the primary care physician that was following the patient in the hospital, and so knew what had happened because they were there caring for the patient. And in the current climate where we have hospitalists that are frequently taking care of patients, it's a bit of a disconnect. I think 30 days is significantly too long in order to be able to just get the information to the primary care physician. I don't think we've specifically talked about it, but most of the readmissions occur probably within the first week to 2 weeks after discharge. And so if the discharge summary isn't even completed until 30 days after discharge, how in the world are we going to be giving information to the PCP to act on at that first visit? I think the other piece of that is, how accurate can a discharge summary be if someone's not doing it until 30 days after they've taken care of a patient? And I think the most appropriate thing to do would be to, as soon as the patient is discharged, complete a discharge summary. So I think there are some things in the system that are really broken, and there really is a lack of infrastructure to facilitate inpatient and outpatient communication. So there are some systems things that I think need to be fixed as part of that. I also wanted to show you some data from a meta-analysis of observational studies that really investigated communication and information transfer at hospital discharge. And again, direct communication was found to occur really infrequently, and only about 3% of the PCPs reported being involved in the discussion about the discharge, with only 17 to 20% reporting being notified about discharges. And I think, at least being notified about discharge would be something that a PCP should know about. Their patient was in the hospital, and now they're coming home, and that they need to follow up on some things. As we've talked about, we don't often fix everything during an acute hospitalization. So this is a very busy graphic, and this is a very interesting article if anybody wants to know about some additional information. But the part I want to focus on is the availability and timeliness of receipt of a discharge summary after discharge by the primary care physician. So we're really just going to focus on the top fourth of this graphic. So basically it's broken down to, did the primary care physician receive the discharge summary within 48 to 72 hours after discharge, within 1 week after discharge, within 2 weeks after discharge, within 4 weeks after discharge, and then at all, which is sad to say that they may not have received the discharge summary at all. And essentially what's reported is the average percentage from the meta-analyses with a range in the parentheses. So only about 1% of primary care physicians received a discharge summary within 48 to 72 hours. Only about 15% received it within 1 week. About a third received it within 2 weeks. half received it within 4 weeks, and only 75% ever received a discharge summary at all. So there's a quarter of patients whose primary care physicians never receive any documentation about what happened in the hospital. And I think that that's really a telling thing if we're not even able to get discharge summaries to the primary care physicians. I think the completeness and accuracy of the information also comes into play, but relative to the amount of time we have to spend together, we're not going to specifically delve into that data. So just to summarize the communication factors that really contribute to problems in handoffs and transitions of care. So a lot of times there can be physician-patient miscommunication. Hospitalists have introduced an additional layer of complexity in terms of the amount of communication that really needs to be happening. Paper medical records can make things more difficult in terms of transmitting information, although I think electronic systems have been put into place, but we haven't necessarily found the best way to utilize, I think, those to their potential. There are lack of financial incentives associated with communication, and certainly while we'd like to think that everything should be tied to really excellent patient care, money does drive what happens in the healthcare profession, and so perhaps some financial incentives would help to bolster communication between our inpatient, our outpatient providers. And the other thing that really can happen is that because patients probably will have multiple medical appointments after their discharge, it can really become overwhelming for patients. So I think thinking about any way we can make it easier for the patient is certainly going to be an important part of this discussion. So the next question that I think we need to answer as part of this talk is, we know that communication is really the big factor that is affecting our transitions of care and our efficacy in terms of effectively transitioning folks from one environment to the other. And the question is, what can we do? How can we make this better? Well, there are lots of national initiatives, just two specifically. We're not going to delve into the Affordable Care Act. We could spend probably a whole presentation, a whole hour just talking about this. But the Affordable Care Act, I think, is a national initiative that really gets at trying to better transition patients from one care arena to the other. The Agency for Healthcare Research and Quality, or AHRQ, has a really nice publication, or has really endorsed 4 goals to decrease preventable readmissions. They're really focused on things that the patient can do, and areas that we can focus on making sure the patient has an understanding about these areas to decrease readmissions. So the first one is know what medication to take and be able to take it. The second one is know the signs of danger and know whom to call if they occur. So part of this is giving the patient a little bit of some triage information to use to figure out when is it appropriate to come to the emergency department, when is it appropriate to call their primary care physician, when is it appropriate to go to the pharmacy and pick up something that's over the counter. Certainly as a community pharmacist could be a huge part of helping with this triage issue, as they really are the most accessible healthcare provider. The next goal is to have a prompt follow-up appointment and be able to keep it. I think probably within a week or 2 weeks after discharge is an important goal for us to think about in patients who are transitioning from inpatient to outpatient. And then understand and be able to follow a self-care program. So I think really empowering the patient to take an active role in their health care is sort of the stance that AHRQ has taken, and I think really an important part of what we should be doing. So I also wanted to just talk briefly about transitions of care models. There have been lots of models that have crept up recently because this is such a hot topic. Some of the models are interdisciplinary. Others really have more of a narrow focus. They specifically focus on a specific area of practice. Generally, it's been either medical or nursing. I really want to talk about a project that's been done that's multidisciplinary, and I think probably going to be the crux for what a lot of people do when it comes to transitions of care. So this is Project RED, or Project Re-engineered Discharge, and in 2004 it was a team at Boston Medical Center that began to examine the discharge process within their institution. Then they put together a discharge package. Really they looked at the areas that they needed to improve on, and then figured out what really they needed to address. What process were they going to put in place to improve their discharge process? So I'm just going to quickly run through the principal themes that they came up with when they studied their discharge process. The first thing they said is that the roles and responsibilities for everyone involved really need to be clearly defined. I think that makes sense because I think the problem when roles and responsibilities are not defined is things slip through the cracks. So it's not so much about overlap. Sometimes I think some overlap is a good thing. If you've got multiple people providing some education, I think sometimes folks need to hear it more than once, but I think making sure everybody understands their role and their responsibility, make sure that there's nothing that's left out. I think the other really key part is that the discharge process has to begin prior to the decision to discharge. The reason is that if we start thinking about what needs to happen to make the discharge process occur effectively, everything is put into place rather than everybody scrambling at the last minute or things not happening because of scrambling at the last minute. So specifically, some things that I tend to think about are, is this medication on the formulary? Can the patient even afford this? Do I need to look at patient assistance programs? Do I need a prior authorization to get this medication? Those types of things, specifically related to what I do. The next piece is patients should be educated throughout the hospitalization. I think this is key too. I know when I have a new start to anticoagulation, one of the things that I really try to do is to get in there early and talk to the patient about their anticoagulation. Part of that is to make sure that they're a good candidate. Are they really going to be able to do this? Are they going to be able to follow up? And making sure that they're going to be safe when they go home. Or maybe it's identifying a family member or someone in the community that would be able to help them if I don't think they're safe, then getting that person in there and providing that education before the discharge happens. So I also think it's a great way, if you start educating early and educating often, it's a way to provide small snippets of information rather than spending an hour on education. You know, patients do better, I think, with small amounts of information more frequently. It also allows you to assess retention of knowledge that you've provided previously or clarify any questions that the patient has. The next piece of that is information should be communicated between the hospital team and the primary care physician. I think that we talked significantly about the problems with communication and that the primary care physician just isn't being kept in the loop when it comes to discharges and hospitalization. I think direct contact or direct communication would be significantly beneficial, but if not, at least providing a timely discharge summary prior to the patient seeing the PCP after discharge. A few more principal themes, actually 2 more slides. The discharge summary should be completed at the time of discharge. That absolutely makes sense. The discharge summary needs to be comprehensive. I've seen some pretty terrible discharge summaries, and so even if you provide a timely discharge summary, but it doesn't contain all of the information or it really says nothing about the hospitalization, it's really doing nobody any good anyhow. They also say that the discharge information should be written in the patient's language and be at their health literacy level. This is important, you know, if we're asking patients to play a more active role and a more active hand in their healthcare, really to help be the bridge to transition them back to care. And this is an important piece of what we need to do. Patients who are at high risk for rehospitalization should have their discharge plan reinforced after discharge. So what a novel concept maybe would be nice if somebody from the inpatient setting gave a quick follow-up phone call after discharge just to see how the patient is doing and talk with them about any issues or any concerns that the inpatient team had about them transitioning back to the community. A few more themes here. All information about the acute hospitalization should be given to the PCP as soon as possible after discharge. We've kind of already talked about that. One of the things that they found in their analysis of their discharge planning process is that they had case management who had limited hours, and case management plays a huge role in terms of coordinating discharges. So really they felt like they needed to be able to expand the discharge hours associated with case management to make sure that there was a case manager present at all times to really facilitate a discharge that would happen safely. And then finally, I think every process really needs to be continuously reassessed to look for additional opportunities to make it better. So then, based on those themes that I've talked about over the last 3 slides, they came up with their discharge plan, and they have an inpatient and an outpatient component. And again, this is a pretty busy couple of slides, so I'm going to highlight the things that are components to their discharge plan to hope improve transitions of care. So the first piece is patients are going to be educated throughout their hospital stay. The second piece is they're going to make appointments with clinicians. And one of the things that they specify about these appointments is the patient needs to be engaged prior to them being made. The times and the dates that their follow-up appointments are occurring should be convenient to the patient. If we don't engage the patient, how are we going to make sure that they can follow up on those dates and their times? It's important for us to discuss the reason and why those appointments are important with the patient so that they want to follow up at their appointments. And we also should coordinate if they have multiple appointments. And then finally, the last piece is make sure the patient knows where the appointment is, they have transportation, and that they're going to be able to make it to that location. We should never just assume someone has transportation or that they know where they're going to be following up. Certainly, folks that work in large healthcare institutions know how confusing finding an outpatient visit can be, particularly if it's based in the hospital. The third piece is that they're going to discuss with the patient any pending in-hospital tests or studies and who they should follow up with for the results. Again, it's engaging the patient in their healthcare so that they can help hold us accountable. The fourth piece I've already mentioned, but it's organized post-discharge services. The fifth piece is to confirm the medication plan. So we need to make sure that we've reconciled the medications, that we've explained them to the patient and emphasized any changes. We've discussed the purpose, how to take it correctly and important side effects, and make sure that the patient has a realistic plan about how to get their medications and that they're going to be able to get their medications. We can do all these wonderful things for patients, but if they can't get their medications, we're not doing anybody any good. The next piece of their discharge process is that the discharge plan should be reconciled with national guidelines, making sure that the things that we're doing for patients are evidence-based. The next part is really to review appropriate steps in terms of what to do if a problem arises. So this is that triage part, giving the patient some instructions on what's an emergency, when do they come to the emergency room, when do they call their primary care physician, what's appropriate based on what's happening. So they are going to transmit the discharge summary to physicians and services accepting the patient's care, and they go over some specific items that should be included as part of this discharge summary, which because of time constraints, we're not going to specifically go into them, but there are a lot of things that we've already talked about. The next important part is assessing the degree of understanding, making sure the patient can explain in their own words the details of the plan. So this goes back to sort of the education and constantly reassessing, making sure the patient is understanding the education that we're providing to them and understanding the plan. Because we can do all this work, and if the patient doesn't understand the plan, really we're not doing anyone very, very much good. We're going to give the patient a copy of the written discharge plan. This is really the after hospital care plan. And then as follow-up, they had a pharmacist who was doing a post-discharge telephone component. And they were calling the patient to reinforce the discharge plan, as well as review medications and solve any problems that arose as a result of their transition back into the community. So I think Project Red has a pretty comprehensive discharge plan and has probably addressed a lot of the issues that have been brought up throughout the literature in terms of issues with communication. So the next piece of their project was to take a look at what difference their intervention made on rehospitalizations or hospital utilization. And so they had about 700 patients that were included, and they randomized them either to receive usual care or to receive the intervention which we've just discussed. And so these are the results for you here. And essentially we have various variables on the left-hand side, and then we have the usual care group, intervention group, and the p-value comparing the two groups. So the first piece of data is the hospital utilization, and it's in visits per patient per month. So this would include both emergency department visits as well as readmissions. So in the usual care group, there were 166 visits, and then in the parentheses, it's 0.451 visits per patient per month. In the intervention group, there were 116 folks who used the hospital in one capacity or another, either an emergency department visit or readmission. So it's 0.314 visits per patient per month. So this is statistically significant, less than 0.05. So they did decrease hospital utilization overall. Then if you break it down into emergency department visits and readmissions, there were 90 folks in the usual care group who came into the emergency department, whereas 60 folks in the intervention group. And again, this was statistically significant at less than 0.05. And then in terms of readmissions, there were 76 folks in the usual care group who came back and were readmitted, 55 in the intervention group. This is not statistically significant with a p-value of 0.09. So it appears that our emergency department visits are driving their data in terms of decreasing hospital utilization. And this is the reason why I think the emergency department visits is really an important part of this conversation. So just to show it to you in another way, this graphic shows the cumulative hazard ratio on the y-axis of being readmitted, and it has the time after index discharge on the x-axis. The usual care group is in the solid line with the intervention group in the dotted line. It's interesting to see where they diverge. It's actually about 10 days after discharge. So it appears that it's at 10 days after discharge that we're able to make the most difference for patients. So just something to keep in mind, but I think they've made some good headway with Project Red. So to wrap up our talk today, I really want to talk about what is the pharmacist's role and what are the responsibilities of the pharmacist in transitions of care. So there was a pretty recent white paper published in Pharmacotherapy, and it really had a nice quote that I think speaks to the role of the pharmacist and what pharmacists have been involved with to this point. So they say, pharmacists are underused during care transitions. In a review of pharmacist services in U.S. hospitals, only 5% of hospitals reported pharmacists provided admission medication histories, and about 50% of hospitals reported that pharmacists provided drug therapy counseling. So before we talk about specific roles and responsibilities of pharmacists, I wanted to just go over the one study that I could find in pharmacy about transitions of care, and it's the MATCH study. So the purpose of this study was to identify and analyze the frequency and types of admission and medication errors on a general internal medicine service. The methods were that pharmacists performed a medication history within 24 to 48 hours of admission, and then pharmacist and physician medication histories were compared, and both histories were compared to the medication orders to see where, if any, errors were occurring. So let's see what they found in terms of results from the MATCH study. So this is a schematic just showing you the various things that they found, the number of medications and patients that were involved in this study. So starting at the very top, there were a little over, almost actually 6,000 history and admission medication orders. And this accounted for a little over 600, about 650 patients. In these medication history and admission orders, they found almost 1,100 unexplained discrepancies in over half of the patients, so 392 patients, where there was some discrepancy found between the pharmacist history, the physician history, and then the medications ordered. They then broke them down by history discrepancies and order discrepancies. So the history discrepancies then follow on the left-hand part of the schematic, whereas the order discrepancies are on the right-hand side of the schematic. So there were 945 medication history discrepancies in 360 patients and 449 medication order discrepancies in 234 patients. Now they did break these down further and classify them a little bit further. So there were 301 discrepancies that originated in histories and then carried through to the admission orders. And then there were 148 discrepancies in the admission orders only, so the pharmacist and the physician histories matched. Taking a look one step further at what they then did with this information with the medication history discrepancies, 792 history discrepancies were clarified and the medical record documentation was corrected. These were classified as history errors. And then in terms of the medication order discrepancies, 449 order discrepancies, so all of them, were clarified with hospital physicians. 309 changes were classified as order errors, so they made changes. There were 140 of these order discrepancies that remained unchanged, so 95 were intended. This makes sense. You think about the patient who comes into the hospital and is hypotensive because they've got an infection or something else going on. And you would hold those antihypertensives in that setting. So there are times where there are purposeful items that occur as part of medication reconciliation that are, medications are not continued but held for the safety of the patient. 34 of these were unchanged for various clinical reasons, and in 11 instances the physician was unable to be reached. So I think this study is very interesting. I think it speaks to why it's so important to have pharmacists be involved in the medication reconciliation and medication history process. I know we see these kinds of things happen all the time in the institution that I round in. So just to summarize the errors that they found and a little bit more about the types of errors, the most frequent error was an error of omission, about 50%. I think this makes sense. I know the majority of patients that I speak to, the majority of them know a decent number of their medications, but it's pretty frequent that they can't remember the details about one medication, or they leave a medication off, especially I think when you start to have more than 5 medications that a patient is taking. After this, dosing errors were the next most common in 30% of the errors, and then following this, it was frequency errors in about 10% of the errors. So the match study is the only data that I could find in this area that really looks at pharmacy data and takes a look at how a pharmacist can be instrumental in medication reconciliation and preventing medication errors associated with transitions of cares. One of the things that I think is really interesting is there's a lot of data about physician communication, but think about all the different areas we have pharmacists, and why isn't there more studies about pharmacist communication? So I see patients in the inpatient setting, and I frequently call community pharmacies when I'm working on my medication histories, making sure they're accurate and better understanding a patient's adherence and medication use behaviors. But I never call that pharmacy back and say, hey, Mr. Smith was discharged and we made these changes. You might want to take a look out for them. Can you just make sure he understands? Or, and I certainly understand there's a lot of community pharmacy settings that are very busy, and that would not be an easy thing to work into the workflow, but at least providing my contact information so that if something came up, they would have someone to contact. Anyhow, that aside, that's something I think I'm interested in looking at in the future, but to take a look at what the specific roles that have been identified for pharmacists in various practice settings, and this by no means is exhaustive, but these come from a white paper that was recently published in the end of 2012 in Pharmacotherapy. So what should inpatient care pharmacists be doing? Participating in rounds, performing medication histories, using their knowledge to anticipate and resolve problems during transitions. One of the things that I think of a lot of times is related to the formulary. Certainly our formulary inpatient is very different from a lot of patients' insurance formularies. So in particular, PPIs, making sure that we figure out which PPI is covered by their insurance, or if it requires prior authorization, doing that prior to the discharge process and making sure that I help the team with those kinds of things. We should be assessing the medication regimen for appropriateness, making sure everything that the patient is taking is actually necessary. Identify any barriers to patient adherence to medication regimens. So I frequently ask patients about cost, and if there's anything that I can do, enrolling patients in patient assistance programs through pharmaceutical companies to help any way I can. We should be providing discharge counseling to patients and/or family members. And then a follow-up phone call within 2 to 4 days after discharge is probably a very beneficial thing, especially if there's any issues that come up. There's something that required prior authorization we didn't realize, that you give the patient some nice medication counseling and to go over the changes at the end, but how much is going on, how much education are they getting at the very end? And our intentions are good, but sometimes that information doesn't always sink in. So just giving a quick follow-up call to see how they're doing. And then providing handoffs to pharmacists, providing care at other levels. And I think this is the piece that I'm really thinking more about in my practice, and how can we better use our pharmacist colleagues to better transition patients into the community. So long-term care pharmacists also have a large role that they can play in these transitions. So performing thorough medication histories and medication reconciliation. When patients enter into long-term care facilities, this is one of the highest risk times for medication errors and errors in transitions. They should be involved in counseling family members when there are changes that occur in a medication regimen, and assess the medication regimen to maximize the benefits of medication therapy while minimizing the risk. Certainly, we know our elderly patients are at a higher risk to experience adverse drug events. And then the last group that they really focused on was the community and ambulatory care pharmacist. And I do recognize there are other areas of practice, but in the interest of time, I wanted to spend time on these particular groups today. And so what they should be involved in is clarifying discrepancies in medication regimens, providing a personal medication record. I also do this sometimes as part of my service, especially when I have pharmacy students on rotation with me. It's a great exercise for them. Creating a medication-related action plan which can be used to communicate with providers, conducting home visits if it's possible, assisting with third-party formulary issues, and then helping patients understand their discharge paperwork. So I think that really there's a ton of things that pharmacists can do as part of the transitions of care process. And I really think there's a lot of opportunities for studies to be done in these groups. There's a lot of things that I think haven't been specifically studied, but certainly would impact and provide better transitions of care for patients if pharmacists had increased levels of communication with one another in the different practice settings. Okay, so thanks everybody for sticking with me. I'd just like to summarize what we talked about today. Transitions of care are vulnerable times for medication errors to occur. Patient characteristics can help us to predict which patients are at the greatest risk for readmission or use of emergency department services soon after discharge. Patients who are discharged from an acute care hospital setting really should have a follow-up visit with their primary care doctor within 1 to 2 weeks after discharge. And finally, what we just talked about, pharmacists are really a vital component in the transition of care process and in the discussion about decreasing hospital readmission rates. So hopefully everybody feels inspired to go out and implement a change in their practice that is going to help us in the transitions of care process.